Let's see how strong your nursing mind really is. These are not your typical NCLEX respiratory questions. They're the kind that make even top students pause and think twice. Every question is built to test how you handle real-life critical care decisions, just like in the hospital. So don't rush. Think through every scenario, because one missed clue could cost your imaginary patient's life. And remember, at the end, you'll see how your score compares to top performers preparing for the NCLEX right now. Ready to test your clinical thinking? Let's begin with question 1. Question 1. A patient with acute respiratory distress syndrome, ARDS, is on mechanical ventilation. The nurse notes a sudden drop in oxygen saturation from 95% to 82%, decreased breath sounds on the right, and tracheal deviation to the left. Which action should the nurse take first? A. Increase VO2 on the ventilator. B. Reassess the ventilator settings. C. Disconnect the ventilator and manually ventilate with 100% O2. D. Notify the healthcare provider immediately. Answer: C. Disconnect the ventilator and manually ventilate with 100% O2. Rationale: these findings suggest a tension pneumothorax, a life-threatening condition. Immediate manual ventilation with 100% oxygen helps maintain oxygenation while preparing for emergency decompression. Strategy: when there's sudden hypoxia in a ventilated patient, always assess airway and ventilation integrity before calling the provider. Question 2. A client with COPD is prescribed 2 liters per minute of oxygen via nasal cannula. The client insists on increasing the flow rate to 5 liters per minute due to shortness of breath. What is the best nursing response? A. Allow the client to increase oxygen as needed. B. Educate the client that too much oxygen can decrease breathing drive. C. Encourage deep breathing and coughing exercises. D. Notify the respiratory therapist. Answer: B. Educate the client that too much oxygen can decrease breathing drive. Rationale: COPD patients rely on hypoxic drive for respiration. Excessive oxygen can lead to CO2 retention and respiratory failure. Strategy: for COPD, remember, maintain oxygen at lowest effective concentration to prevent CO2 narcosis. Question 3. A nurse is caring for a patient with a chest tube connected to a water seal drainage system. Which finding requires immediate intervention? A. Continuous bubbling in the suction control chamber. B. Fluctuation, tidling, in the water seal chamber during respiration. C. Absence of tidling in the water seal chamber. D. Drainage of 60 milliliters of serosanguinous fluid in the past hour. Answer: C. Absence of tidling in the water seal chamber. Rationale: lack of tidling may indicate tube obstruction or lung re-expansion. Obstruction prevents drainage and can cause tension pneumothorax. Strategy: always assess chest tube patency and drainage system function first when abnormalities occur. Question 4. A client with pneumonia is receiving 4 antibiotics and oxygen therapy. The nurse notes increased confusion and restlessness. Which action should be prioritized? A. Assess for hypoxemia and obtain ABG. B. Reorient the client and provide safety. C. Notify the provider of behavioral changes. D. Increase oxygen flow rate. Answer: A. Assess for hypoxemia and obtain ABG. Rationale: early signs of hypoxia include restlessness, confusion, and agitation. Assessment and ABG analysis are priority before making oxygen changes. Strategy: when behavior changes occur in respiratory patients, suspect decreasing oxygenation first. Question 5. A postoperative patient following thoracotomy is being monitored. Which finding requires immediate nursing intervention? A. Pain score of 8 out of 10. B. Saturation drop from 96% to 88%. C. Small amount of serous drainage from incision. D. Shallow respirations due to pain. Answer: B. Saturation drop from 96% to 88%. Rationale: desaturation indicates impaired gas exchange or possible lung collapse. Prompt oxygen administration and airway assessment are needed. Strategy: airway and oxygenation always override pain management in priority setting. Question 6. A nurse observes a patient with a tracheostomy coughing up large amounts of thick, yellow sputum. The patient's respiratory rate is 32 per minute, and oxygen saturation is 86%. What is the nurse's priority action? A. Encourage fluid intake. B. Perform tracheal suctioning. C. Administer a bronchodilator. D. Notify the respiratory therapist. Answer: B. Perform tracheal suctioning. Rationale: the patient shows signs of airway obstruction from mucus accumulation. Immediate suctioning restores airway patency and oxygenation. Strategy: for tracheostomy patients, always maintain airway clearance as the top priority. Question 7. A nurse is monitoring a patient with pulmonary embolism, PE. Which finding indicates a life-threatening complication is developing? A. Tachycardia and dyspnea. B. Hemoptysis. C. Jugular vein distension and hypotension. D. Chest pain increasing on inspiration. Answer: C. Jugular vein distension and hypotension. Rationale: these signs suggest obstructive shock from massive PE, leading to right ventricular failure. This requires immediate intervention, thrombolytics or embolectomy. Strategy: prioritize hemodynamic instability and shock signs over respiratory discomfort. Question 8. The nurse is caring for a client receiving continuous positive airway pressure, CPAP, for sleep apnea. Which observation requires immediate action? A. Mild nasal dryness. B. Air leak around the mask. C. Complaints of claustrophobia. D. Increasing daytime somnolence. Answer: D. Increasing daytime somnolence. Rationale: this indicates ineffective therapy, possible non-compliance or CPAP malfunction, leading to persistent hypoxemia and hypercapnia. Strategy: when therapy outcomes worsen, assess effectiveness and compliance before comfort measures. Question 9. A patient with acute asthma exacerbation is being treated with albuterol nebulization. Which finding requires the nurse's immediate action? A. Heart rate increase from 90 to 110 bpm. B. Wheezing decreases but breath sounds become silent. C. Patient complains of tremors and headache. D. Productive cough with thick sputum. Answer: B. Wheezing decreases but breath sounds become silent. Rationale: silent chest in asthma signals severe airway obstruction and impending respiratory arrest. Emergency intervention is required. Strategy: when wheezing stops suddenly, think complete obstruction, not improvement. Question 10. A client with tuberculosis, TB, is started on isoniazid and rifampin. Which lab result requires priority follow-up? A. ALT180U/L. B. Hemoglobin 12.5G/DL. C. Platelets 220,000/mm superscript 3. D. Sodium 138 milliequivalent/L. Answer: A. ALT180U/L. Rationale: elevated liver enzymes indicate hepatotoxicity, a serious side effect of both drugs. Therapy should be stopped and the provider notified. Strategy: always monitor liver function tests for patients on TB medications. Question 11. A client with cystic fibrosis, CF, produces copious thick secretions and has a sudden spike in temperature, increased WBC, and new focal crackles in the right lower lobe. Which action should the nurse take first? A. Increase airway clearance frequency, postural drainage/chest physiotherapy. B. Obtain sputum culture and start antibiotics per protocol. C. Encourage aggressive hydration and mucolytics. D. Administer bronchodilator and assess response. Answer: B. Obtain sputum culture and start antibiotics per protocol. Rationale: new fever, leukocytosis, and focal crackles indicate possible bacterial pneumonia. Culture-guided antibiotics are priority to treat infection in CF where pathogens can rapidly worsen. Strategy: for CF with systemic infection signs, prioritize diagnostics and initiation of targeted therapy along with airway clearance. Question 12. A mechanically ventilated patient has a plateau pressure, PLAT, rising above 30 cm H2O while peak pressures remain stable. What does this indicate and what is the immediate implication? A. Increased airway resistance, suction patient. B. Decreased lung compliance, risk for barotrauma, adjust ventilator strategy. C. Circuit obstruction, change tubing. D. Patient ventilator asynchrony, increase sedation. Answer: B. Decreased lung compliance, risk for barotrauma, adjust ventilator strategy. Rationale: PLAT reflects alveolar pressure and lung compliance. Rising PLAT with stable peak suggests reduced compliance, ARDS, pulmonary edema, pneumothorax. High PLAT increases barotrauma risk. Ventilator settings, lower tidal volumes, permissive hypercapnia, must be considered. Strategy: distinguish peak versus plateau pressures, plateau compliance, peak resistance. Question 13. A patient with severe community-acquired pneumonia develops acute kidney injury, AKI. The provider orders vancomycin and piperacillin-tazobactam. Which nursing consideration is most important? A. Ensure dosing times are documented. B. Monitor trough vancomycin levels and renal function closely. C. Teach the patient about antibiotic side effects. D. Start probiotics to prevent C. difficile. Answer: B. Monitor trough vancomycin levels and renal function closely. Rationale: vancomycin is nephrotoxic. Combined with AKI and other beta-lactams risk, monitoring serum levels and renal function is critical to avoid accumulation and further renal damage. Strategy: when antibiotics with nephrotoxicity are used in AKI, prioritize therapeutic drug monitoring and renal labs. Question 14. A client in the emergency department presents with suspected inhalation injury after a house fire. Which assessment finding requires immediate airway intervention? A. Facial burns and singed nasal hair. B. Hoarseness, stridor, and drooling. C. Carbonaceous sputum on coughing. D. Burned eyebrows only. Answer: B. Hoarseness, stridor, and drooling. Rationale: progressive upper airway edema can rapidly compromise the airway after inhalation injury. Hoarseness and stridor are early signs of impending obstruction requiring early intubation. Strategy: in inhalation exposures, act early on airway signs, anticipate difficult airways and secure before edema worsens. Question 15. A patient with advanced COPD has a PaCO2 of 68 mm of mercury and pH 7.30 on ABG. The nurse notes the patient is drowsy and hypoventilating. Which action is most appropriate? A. Increase oxygen to 6 liters per minute via nasal cannula. B. Initiate non-invasive positive pressure ventilation, BiPAP, and call provider. C. Administer a sedative to treat anxiety. D. Encourage pursed lip breathing only. Answer: B. Initiate non-invasive positive pressure ventilation, BiPAP, and call provider. Rationale: hypercapnic respiratory failure with somnolence indicates ventilatory failure. BiPAP can improve alveolar ventilation and CO2 elimination. Escalating respiratory support is needed. Excessive oxygen may worsen CO2 retention. Strategy: for hypercapnia and decreased consciousness, support ventilation rather than increasing oxygen alone. Question 16. A patient with pulmonary arterial hypertension, PAH, is admitted with worsening dyspnea and peripheral edema. Which medication class is most likely used to reduce pulmonary vascular resistance and should be expected in care? A. Beta blockers. B. Calcium channel blockers or prostacyclin analogs. C. ACE inhibitors. D. Loop diuretics only. Answer: B. Calcium channel blockers or prostacyclin analogs. Rationale: PAH management may include calcium channel blockers, in select responders, prostacyclin analogs, endothelin receptor antagonists, and phosphodiesterase 5 inhibitors to reduce pulmonary vascular resistance. Diuretics address volume but don't treat pulmonary vasculature. Strategy: identify disease-specific vasodilators for PAH. Diuretics treat symptoms but not the underlying pulmonary vascular pathology. Question 17. A patient with possible tuberculosis is placed in airborne isolation. Which action by a new nurse requires correction? A. Staff entering the room wear an N95 respirator. B. The patient leaves the room for a CT scan wearing a surgical mask. C. The door to the room is left open while staff are present. D. A private negative pressure room is used. Answer: C. The door to the room is left open while staff are present. Rationale: airborne precautions require doors to remain closed and use of negative pressure isolation. An open door risks aerosol spread. Strategy: for airborne pathogens, ensure negative pressure room, N95, and closed doors. Surgical masks for patient transport are appropriate. Question 18. A nurse is caring for a patient on high-flow nasal cannula, HFNC. The patient becomes agitated and begins to tug at the cannula, dislodging it intermittently. SpO2 falls to 85%. What is the next best action? A. Reassure the patient and reapply cannula later. B. Remove HFNC and switch to a simple face mask immediately. C. Hold the patient's hands to prevent removal. D. Apply a surgical mask over the cannula and consider escalation to NIV or intubation. Answer: D. Apply a surgical mask over the cannula and consider escalation to NIV or intubation. Rationale: HFNC provides high flow, heated oxygen. Agitation leading to dislodgement causes hypoxemia. A surgical mask over HFNC can improve FiO2 delivery. Persistent hypoxemia or agitation may require escalation to non-invasive ventilation or intubation. Physical restraint without consent or safety plan is not preferred. Strategy: for dislodged HFNC, prioritize oxygen delivery restoration and escalate respiratory support as indicated. Question 19. A patient with ARDS is placed in prone positioning. Which statement about prone positioning is accurate and what nursing priority applies? A. Prone positioning worsens oxygenation and should be avoided. B. Prone positioning can improve V/Q matching, monitor for pressure injuries and secure lines/tubes. C. Prone positioning is only cosmetic and has no physiologic benefit. D. Prone positioning eliminates need for sedation. Answer: B. Prone positioning can improve V/Q matching, monitor for pressure injuries and secure lines/tubes. Rationale: proning improves oxygenation by recruiting dorsal lung units and improving V/Q. It carries risks, pressure injuries, tube dislodgement, and facial edema, so vigilant monitoring and securement are required. Strategy: if proning is used, have protocols for turning, monitoring, and protecting skin/airway. Question 20. A client on a ventilator develops sudden subcutaneous emphysema around the neck and chest. Their oxygen saturation decreases and breath sounds are diminished on one side. What is the most likely cause and immediate nursing action? A. Pulmonary embolism, start anticoagulation. B. Tension pneumothorax, prepare for needle decompression and notify provider. C. Ventilator malfunction, change ventilator. D. Fluid overload, give diuretics. Answer: B. Tension pneumothorax, prepare for needle decompression and notify provider. Rationale: subcutaneous emphysema with unilateral diminished breath sounds and desaturation suggests pneumothorax, possibly tension. Immediate decompression is life-saving. Strategy: recognize signs of barotrauma in ventilated patients and act quickly for decompression. Question 21. A patient with severe asthma receives continuous nebulized albuterol and 4-magnesium sulfate. After therapy, ABG reveals pH 7.48, PaCO2 30 mm of mercury, PaO2 75 mm of mercury. How should the nurse interpret these ABG results? A. Respiratory acidosis with hypoxemia. B. Respiratory alkalosis from hyperventilation, assess for fatigue and worsening obstruction. C. Metabolic alkalosis. D. Normal ABG. Answer: B. Respiratory alkalosis from hyperventilation, assess for fatigue and worsening obstruction. Rationale: low PaCO2 and high pH indicate respiratory alkalosis due to hyperventilation. In asthma, initial hyperventilation can precede fatigue and rising CO2, a normalizing or rising PaCO2 later is ominous. PaO2 is borderline, monitor closely. Strategy: track trends. Falling PaCO2 in acute asthma may temporarily reflect hyperventilation, but watch for sudden CO2 retention as fatigue sets in. Question 22. A patient with severe obstructive sleep apnea, OSA, is non-compliant with CPAP and asks about surgical options. Which procedure is most appropriate for an adult with an isolated structural cause at the soft palate? A. Tracheostomy. B. Uvulopalato-pharyngoplasty, UPPP. C. Tonsillectomy only. D. LASIK. Answer: B. Uvulopalato-pharyngoplasty, UPPP. Rationale: UPPP removes excess tissue in the oropharynx, uvula, soft palate, and can be effective for OSA due to soft palate obstruction. Tracheostomy is reserved for severe, refractory cases. Strategy: identify anatomical causes and match to surgical options. CPAP remains first line. Question 23. A patient with pulmonary fibrosis is undergoing evaluation. Which pulmonary function test pattern and finding would the nurse expect? A. Obstructive pattern with increased TLC. B. Restrictive pattern with decreased total lung capacity, TLC, and decreased diffusion capacity, DLCO. C. Normal PFTs with airflow obstruction on spirometry only. D. Increased residual volume with normal DLCO. Answer: B. Restrictive pattern with decreased total lung capacity, TLC, and decreased diffusion capacity, DLCO. Rationale: interstitial lung disease/pulmonary fibrosis causes restrictive physiology and impaired gas transfer, decreased TLC and DLCO. Strategy: link interstitial processes to restrictive PFTs plus low DLCO. Question 24. A patient admitted with severe influenza develops acute respiratory failure and is placed on ECMO, veno-venous. What is the nurse's highest monitoring priority specific to ECMO? A. Frequent neurochecks only. B. Monitor anticoagulation parameters and assess for bleeding and circuit integrity. C. Encourage patient mobilization immediately. D. Stop all antibiotics. Answer: B. Monitor anticoagulation parameters and assess for bleeding and circuit integrity. Rationale: ECMO requires systemic anticoagulation to prevent circuit thrombosis and carries high bleeding risk. Monitoring coagulation and circuit function is critical. Strategy: for ECMO patients, prioritize anticoagulation management and vigilant surveillance for bleeding and mechanical complications. Question 25. A patient with bronchiectasis reports increased sputum volume and foul odor. Which test or action is most appropriate next? A. Start inhaled corticosteroids immediately. B. Obtain sputum culture and sensitivity and start appropriate antibiotics. C. Schedule bronchoscopy immediately. D. Increase inhaled bronchodilator dose only. Answer: B. Obtain sputum culture and sensitivity and start appropriate antibiotics. Rationale: foul-smelling sputum and increased volume suggest infective exacerbation with possible anaerobic or unusual organisms. Culture guides antibiotic therapy. Bronchodilators/inhaled steroids are adjuncts. Strategy: in bronchiectasis exacerbations, culture-driven antibiotics are essential. Question 26. A patient with acute exacerbation of COPD is started on systemic corticosteroids. Which complication is most important for the nurse to monitor in the immediate term? A. Hyperglycemia and infection risk. B. Osteoporosis in 2 weeks. C. Cataract formation. D. Chronic weight gain over months. Answer: A. Hyperglycemia and infection risk. Rationale: systemic steroids rapidly cause hyperglycemia and immunosuppression, increasing infection risk. Other complications are longer term. Strategy: monitor glucose and signs of infection when administering systemic steroids acutely. To stay updated with future videos like this, don't forget to like this video and subscribe to the channel. Welcome back. Question 27. A patient with suspected aspiration pneumonia has decreased breath sounds and dullness to percussion at the right lower lobe. Which diagnostic study is most appropriate to confirm diagnosis and guide treatment? A. Chest X-ray, upright, then CT if needed. B. V/Q scan. C. Pulmonary function tests. D. ECG. Answer: A. Chest X-ray, upright, then CT if needed. Rationale: chest X-ray can identify lobar consolidation consistent with aspiration, CT gives greater detail. D/Q is for PE, not pneumonia. Strategy: use imaging, CXR-CT, to confirm aspiration and plan antibiotics. Question 28. A patient develops acute hemoptysis of 300 milliliters over 2 hours and becomes hypotensive. What is the priority nursing action? A. Position the patient on the affected side. B. Administer cough suppressant and observe. C. Place patient upright and prepare for emergent bronchoscopy or interventional radiology, embolization. D. Send sputum for cytology. Answer: C. Place patient upright and prepare for emergent bronchoscopy or interventional radiology, embolization. Rationale: massive hemoptysis with hemodynamic instability is life-threatening. Interventions to localize and stop bleeding, bronchoscopy, bronchial artery embolization, are urgent. Positioning upright helps airway protection and drainage. Strategy: for massive hemoptysis, protect airway, stabilize hemodynamics, and arrange definitive control of bleeding. Question 29. A patient with suspected pulmonary embolism is hemodynamically unstable. Which immediate diagnostic or therapeutic step is appropriate? A. Wait for CT pulmonary angiography only. B. Begin empiric anticoagulation or consider thrombolytics if confirmed and no contraindications. C. Administer antibiotics for possible pneumonia. D. Schedule a ventilation perfusion scan. Answer: B. Begin empiric anticoagulation or consider thrombolytics if confirmed and no contraindications. Rationale: hemodynamic instability with high suspicion for massive PE warrants urgent anticoagulation and, if confirmed or strongly suspected with shock, thrombolysis may be life-saving. CT may not be feasible. Strategy: in unstable suspected PE, treat for PE immediately while arranging diagnostics. Question 30. During a suctioning attempt of a tracheostomy patient, the patient develops bradycardia and desaturation. What should the nurse do immediately? A. Continue suctioning until secretions cleared. B. Remove the catheter, provide 100% oxygen, and assess the patient. C. Instill normal saline down the tracheostomy and suction again. D. Increase suction pressure. Answer: B. Remove the catheter, provide 100% oxygen, and assess the patient. Rationale: vagal stimulation during suctioning can cause bradycardia and desaturation. Immediate removal of the suction catheter and oxygenation is required. Instilling saline is generally discouraged, it can worsen hypoxia. Strategy: if adverse events occur during suctioning, stop, oxygenate, and reassess. Question 31. A patient with influenza is being screened for secondary bacterial pneumonia. Which lab/clinical pattern suggests a secondary bacterial infection rather than primary viral process? A. Gradual improvement followed by return of high fever, productive cough, and leukocytosis with left shift. B. Persistent low-grade fever and dry cough only. C. Leukopenia with lymphocytosis. D. Normal WBC with high CRP only. Answer: A. Gradual improvement followed by return of high fever, productive cough, and leukocytosis with left shift. Rationale: secondary bacterial pneumonia often follows an initial viral improvement, then acute deterioration with purulent sputum and neutrophilic leukocytosis. Strategy: look for biphasic illness, improvement then worsening with bacterial features. Question 32. A newly intubated patient has an endotracheal tube secured at 22 centimeters at the teeth. The nurse notes unequal chest rise and diminished breath sounds on the left. What is the likely problem and immediate step? A. Endobronchial intubation of right mainstem, withdraw the tube slightly and reassess breath sounds/ETCO2. B. Left mainstem intubation, advance the tube further. C. Positioning error only, turn patient to left side. D. Tube depth is ideal, increase ventilator rate. Answer: A. Endobronchial intubation of right mainstem, withdraw the tube slightly and reassess breath sounds/ETCO2. Rationale: diminished left breath sounds and unilateral right chest rise suggest right mainstem intubation. The tube should be pulled back a few centimeters and reassessed. Strategy: after intubation, confirm tube position by bilateral breath sounds, chest rise, and EtCO2, correct malposition promptly. Question 33. A postoperative patient on PCA opioid analgesia develops decreased respiratory rate, pinpoint pupils, and decreased responsiveness. What is the immediate nursing action? A. Administer naloxone per protocol and support airway/ventilation. B. Reduce PCA settings and observe. C. Give oxygen via nasal cannula only. D. Encourage deep breathing and coughing. Answer: A. Administer naloxone per protocol and support airway/ventilation. Rationale: signs indicate opioid overdose causing respiratory depression, naloxone reversal and airway support are life-saving. Strategy: recognize opioid toxicity quickly and reverse while maintaining ventilation. Question 34. A patient with COPD and chronic CO2 retention has an ABG, pH 7.37, PaCO2 56 mm of mercury, HCO3 31 milliequivalent/L. How should the nurse interpret these results? A. Normal ABG. B. Metabolic acidosis. C. Chronic respiratory acidosis with metabolic compensation, expected baseline, compare to prior values. D. Acute respiratory alkalosis. Answer: C. Chronic respiratory acidosis with metabolic compensation, expected baseline, compare to prior values. Rationale: elevated PaCO2 with near-normal pH and elevated HCO3 indicates chronic respiratory acidosis with renal compensation seen in COPD. Clinical context and trends matter. Strategy: for chronic lung disease, use prior ABGs to determine acute on chronic changes. Question 35. A patient with severe myasthenia gravis is showing signs of respiratory muscle fatigue, weak cough, inability to lift head, and declining vital capacity. What assessment threshold indicates the need for intubation? A. Vital capacity less than 15 milliliters per kilogram or negative inspiratory force less negative than -20 centimeters H2O. B. Respiratory rate of 16 per minute only. C. Oxygen saturation 96% on room air. D. Ability to speak in full sentences. Answer: A. Vital capacity less than 15 milliliters per kilogram or negative inspiratory force less negative than -20 centimeters H2O. Rationale: these thresholds indicate impending respiratory failure due to neuromuscular weakness. Elective intubation should be considered before emergency. Strategy: in neuromuscular disease, monitor VC and NIF to time respiratory support. Question 36. A patient with suspected chemical pneumonitis after aspiration of gastric contents is being treated. Which intervention is contraindicated? A. Early bronchoscopy for airway clearance if indicated. B. Immediate antibiotic therapy in all cases. C. Supportive care, oxygen, possible ventilation support. D. Close observation and directed antibiotics if secondary infection develops. Answer: B. Immediate antibiotic therapy in all cases. Rationale: chemical pneumonitis, sterile inflammation, does not always require antibiotics unless there is evidence of secondary bacterial infection. Routine antibiotics are not indicated. Strategy: differentiate sterile chemical injury from infectious processes, treat supportively and use antibiotics selectively. Question 37. A patient with pulmonary edema due to left-sided heart failure has pink, frothy sputum, severe dyspnea, and fine crackles bilaterally. Which immediate orders will the nurse anticipate? A. For loop diuretic, morphine, oxygen, and possible CPAP/NIP. B. Oral antibiotics and bronchodilators only. C. Immediate chest tube insertion. D. Nebulized epinephrine only. Answer: A. For loop diuretic, morphine, oxygen, and possible CPAP/NIP. Rationale: acute cardiogenic pulmonary edema requires diuresis, preload reduction, oxygenation, and non-invasive ventilation can improve oxygenation and reduce work of breathing. Morphine is sometimes used cautiously to reduce anxiety and preload. Strategy: treat the underlying cardiac etiology and support oxygenation and ventilation urgently. Question 38. A nurse is caring for a patient after pulmonary angiography. Which post-procedure assessment finding is most concerning? A. Small bruise at the groin access site. B. A hematoma with expanding swelling and decreased distal pulses in the leg used for access. C. Mild back discomfort. D. Transient dysphagia. Answer: B. A hematoma with expanding swelling and decreased distal pulses in the leg used for access. Rationale: an expanding hematoma and compromised distal perfusion suggest vascular injury or ongoing bleeding, urgent vascular surgery or interventional radiology consultation needed. Strategy: after vascular procedures, monitor access site for bleeding and distal perfusion, act on signs of compartment syndrome or arterial compromise. Question 39. A patient receiving ribavirin for RSV therapy is being cared for on the pediatric unit. What special nursing precaution is required? A. Ribavirin requires airborne precautions for the patient. B. Pregnant nurses must avoid exposure to ribavirin aerosol. C. No special precautions are needed. D. Only hand hygiene is necessary. Answer: B. Pregnant nurses must avoid exposure to ribavirin aerosol. Rationale: ribavirin is teratogenic, aerosolized drug requires precautions to prevent occupational exposure, pregnant staff should avoid contact. Strategy: no drug-specific occupational hazards and protect staff, especially pregnancy risks. Question 40. A patient with long-standing interstitial lung disease is being evaluated for lung transplantation. Which criterion would typically exclude them from transplant candidacy? A. Age over 65 automatically excludes them. B. Active substance abuse or non-adherence to medical therapy. C. Presence of pulmonary hypertension only. D. Oxygen dependence. Answer: B. Active substance abuse or non-adherence to medical therapy. Rationale: transplant candidacy requires ability to adhere to complex regimens. Active substance abuse or inability to comply is a common contraindication. Age alone is not an absolute exclusion, individual assessment is used. Strategy: focus on modifiable and behavioral contraindications in transplant evaluation. Question 41. A patient on low molecular weight heparin, LMWH, for DVT prophylaxis needs urgent intubation for respiratory failure. Which anticoagulation consideration is most important? A. LMWH has a long half-life, anticipate bleeding risk at procedure and discuss reversal/holding with team. B. No need to consider anticoagulation for intubation. C. Give additional LMWH before procedure. D. Use aspirin to reverse effects. Answer: A. LMWH has a long half-life, anticipate bleeding risk at procedure and discuss reversal/holding with team. Rationale: LMWH increases bleeding risk during invasive procedures, plan timing of doses, use reversal strategies if necessary, and communicate with procedural team. Strategy: always evaluate anticoagulant timing before invasive airway procedures. Question 42. A patient is being discharged on home oxygen. Which instruction is essential to include in discharge teaching? A. Smoking is permitted if oxygen is less than 2 liters per minute. B. Avoid open flames and smoking around oxygen, ensure proper storage and tubing safety. C. Oxygen tubing may be used while cooking over open flames. D. Keep oxygen cylinder inverted. Answer: B. Avoid open flames and smoking around oxygen, ensure proper storage and tubing safety. Rationale: oxygen supports combustion, smoking or open flames near oxygen is dangerous. Proper storage and tubing management prevent falls/trips. Strategy: emphasize fire safety and proper equipment handling in home oxygen education. Question 43. A patient with RSV bronchiolitis is dehydrated with tachypnea and poor oral intake. Which intervention is priority? A. Start 4 fluids or consider nasogastric/4 hydration to maintain hydration and support respiratory effort. B. Wait for oral intake to improve spontaneously. C. Start broad-spectrum antibiotics immediately. D. Give albuterol prophylactically for all bronchiolitis patients. Answer: A. Start 4 fluids or consider nasogastric/4 hydration to maintain hydration and support respiratory effort. Rationale: infants/children with bronchiolitis often need hydration support because tachypnea impairs feeding. Maintaining hydration is essential. Antibiotics are not routinely indicated unless bacterial infection suspected. Bronchodilators are not universally recommended. Strategy: in pediatric respiratory illnesses, address hydration and work up breathing promptly. Question 44. A patient with emphysema has a flattened diaphragm on chest X-ray and pursed lip breathing. Which pathophysiologic change explains these findings? A. Increased elastic recoil and decreased residual volume. B. Air trapping leading to hyperinflation and increased residual volume, diaphragmatic flattening. C. Interstitial fibrosis causing restriction. D. Pulmonary edema causing alveolar filling. Answer: B. Air trapping leading to hyperinflation and increased residual volume, diaphragmatic flattening. Rationale: emphysema destroys alveolar walls leading to air trapping and hyperinflation, raising residual volume and flattening the diaphragm. Pursed lip breathing helps exhalation. Strategy: correlate physical exam and imaging with COPD pathophysiology. Hyperinflation is key. Question 45. A patient on warfarin is scheduled for a bronchoscopy with biopsy due to lung mass. INR is 3.2. What is the appropriate peri-procedure plan? A. Proceed with biopsy regardless of INR. B. Withhold warfarin and reduce INR to acceptable range per protocol. Consider bridging if high thrombotic risk. C. Increase warfarin dose before procedure. D. Give vitamin K immediately and proceed. Answer: B. Withhold warfarin and reduce INR to acceptable range per protocol. Consider bridging if high thrombotic risk. Rationale: invasive procedures with bleeding risk require warfarin reversal/hold to lower INR. Decisions on bridging depend on thrombotic risk. Vitamin K may be used per protocol. Strategy: balance bleeding versus thrombosis risk. Coordinate with procedural team and pharmacy for peri-procedural anticoagulation management. Question 46. A patient with suspected hypersensitivity pneumonitis, HP, reports symptoms worsened after exposure to mold in attic. Which diagnostic and management steps are indicated? A. Ignore exposure history, treat with antibiotics. B. Remove exposure source, perform HRCT and pulmonary function testing, including DLCO, and consider corticosteroids for acute severe cases. C. Immediate lung transplant referral. D. Only treat with bronchodilators. Answer: B. Remove exposure source, perform HRCT and pulmonary function testing, including DLCO, and consider corticosteroids for acute severe cases. Rationale: HP is exposure-driven, removal of the offending antigen is primary. HRCT and PFTs help diagnose, steroids are used for inflammation control in severe cases. Strategy: environmental history is crucial, stop exposure first, then evaluate and treat inflammation if needed. Question 47. A patient with severe COPD awaiting discharge is increasingly anxious about breathlessness. Which non-pharmacologic intervention should the nurse teach that can immediately help reduce dyspnea? A. Pursed lip breathing and diaphragmatic, abdominal, breathing techniques. B. Avoid movement entirely forever. C. Rapid, shallow breathing. D. Holding breath intermittently. Answer: A. Pursed lip breathing and diaphragmatic, abdominal, breathing techniques. Rationale: these techniques reduce air trapping, improve ventilatory efficiency, and can quickly reduce dyspnea and anxiety. Strategy: teach practical breathing strategies patients can use during dyspnea episodes. Question 48. A patient with pulmonary alveolar proteinosis, PAP, is hypoxemic and scheduled for whole lung lavage. What is a key perioperative nursing consideration? A. Whole lung lavage requires single lung ventilation and careful monitoring of oxygenation and fluid balance during the procedure. B. It is a simple outpatient bronchoscopy without risks. C. No special monitoring is needed beyond routine vital signs. D. Avoid intubation at all costs. Answer: A. Whole lung lavage requires single lung ventilation and careful monitoring of oxygenation and fluid balance during the procedure. Rationale: whole lung lavage is complex, requiring general anesthesia, one lung ventilation, and meticulous fluid management. Risks include hypoxemia and fluid overload. Strategy: anticipate respiratory and hemodynamic instability, coordinate closely with anesthesia and pulmonary teams. Question 49. A patient with multilobar bacterial pneumonia is not improving on standard antibiotics. Cultures return positive for Pseudomonas aeruginosa resistant to multiple agents. What is the likely next step? A. Consult infectious disease for targeted therapy including possible combination antibiotics or inhaled antibiotics. B. Continue current antibiotics indefinitely. C. Start antifungal therapy empirically. D. Discontinue all antibiotics. Answer: A. Consult infectious disease for targeted therapy including possible combination antibiotics or inhaled antibiotics. Rationale: multi-drug resistant Pseudomonas require specialist input for combination therapy, dosing adjustments, and alternative agents. Inhaled antibiotics may be adjunctive. Strategy: use multidisciplinary collaboration for resistant organisms and individualized antibiotic plans. Question 50. A patient with neuromuscular disease develops aspiration with recurrent pneumonias. The multidisciplinary team suggests considering a feeding tube to reduce aspiration risk. Which statement reflects best practice? A. Enteral feeding via gastrostomy eliminates aspiration risk completely. B. Enteral feeding reduces but does not eliminate aspiration risk. Evaluate for swallow therapy, positioning, and consider combined strategies. C. NPO and nothing else will solve the problem long term. D. Only parenteral nutrition should be used. Answer: B. Enteral feeding reduces but does not eliminate aspiration risk. Evaluate for swallow therapy, positioning, and consider combined strategies. Rationale: gastrostomy feeding lowers oral aspiration but does not eliminate risk of aspiration of refluxed gastric contents. Combined strategies: swallow therapy, positioning, medication to reduce reflux, often needed. Strategy: use a comprehensive approach, nutrition support plus aspiration prevention measures and rehabilitation. If you made it all the way here, you're part of a small group of nurses who don't just study, they master. Every question you answered sharpened your ability to think like a real RN under pressure. Now tell me in the comments, how many did you get right out of 50? I read every single comment because your progress matters here. Don't stop now. The next set of questions could be the exact ones that appear on your NCLEX. Hit subscribe, turn on the bell, and get ready, your NCLEX success story starts here.